Epistaxis is a relatively common problem that presents to the emergency department. It can range from minimal bleeding that has ceased prior to arrival to potentially life-threatening hemorrhage and concurrent airway compromise. I frequently see ED doctors struggling to assess and treat patients with epistaxis effectively, but there are some simple techniques you can use that will not only make your patient more comfortable and easier to assess, but will also make your treatments more likely to succeed. This is a long video, so I won't be talking about the pathophysiology of epistaxis or the assessment and management of reversible underlying causes, as there are many blog posts dedicated to these topics already. I also won't be talking about the management of massive facial hemorrhage associated with trauma, as I will cover this in a separate video. In this video, I demonstrate my approach to the assessment and management of the patient with epistaxis and cover patient positioning, lighting and magnification, equipment, drugs, and basic and advanced nasal packing techniques. So Maddie's going to help me out. Thanks, Maddie.
No worries.
So there's a couple of things about epistaxis that really help. First is turn the suction off, so it doesn't make too much noise on your video. You've got to get your equipment ready. You need a fair bit of stuff to do epistaxis properly. And I've got a trolley here next to me, next to the patient. Quiet space, plenty of room to work. Get a dressing pack out. The first thing you need is the butt plug or 2 tongue depressors taped together. You need a dressing pack with some gauze, some tweezers, little plastic tongs, not metal ones. You'll see why you need these in a minute. Nasal speculum or an alternative type of nasal speculum. You need the suction catheter, which has a little blue plastic adapter that goes onto the little fine bore sucker, and you'll see how that works in a minute. So you have to have suction, you have to have some dilators, you also must have some light. You cannot do epistaxis with one hand holding a light and the other hand trying to use equipment. It doesn't work. You'll see why in a minute. You need 2 hands. So you need some sort of head torch, preferably with magnification, some sort of loops or something. So I've got those on now. Tighten them up at the back. It's partly to stop the blood spraying in your eyes and partly to get some magnification so you can see up people's noses properly and see what you're doing. It looks crazy, but it really does help. The other thing you're going to need, and I'll put this on in a second, is a mask to stop the blood spraying on you when the patient coughs or sneezes. Alright, as far as patient preparation, turn my light off. You need the patient sitting as upright as possible in the bed because the blood is going to want to run down their nose. What patients tend to do when they come in is keep dabbing, 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 sitting back, it goes back down the nose, they cough and splutter. If you sit them bolt upright like Maddie, give them a vomit bag to spit up blood into. Put a towel across their front and just say to them, listen, don't worry if the blood just drips on you, it's fine. Always give them some tissues or something to wipe with as well, bag to spit in. Have your suction catheter ready. If they're torrential, you want the big yanker sucker, but most epistaxis, you actually take that off and use the fine bore sucker, which just plugs into the end of the suction tubing. That connection works really well, and I have that sitting in the back of the bed. All right, a couple of other things you might want to get ready are some drugs. So I've got a selection of drugs here and I'll put some photos of these up. So first one is straight adrenaline, 1 in 1,000. It's a milligram in a mil. You might want to use something more dilute because if you get some systemic absorption, theoretically that might not be so good. This is 1 in 10,000 adrenaline, so it's a milligram in 10 mils, or lidocaine and adrenaline. So any of these, something with some vasoconstrictor in it, you might want to use. The other thing you must have is cophenolcaine spray with a little plastic adapter nozzle on the bottle. Give it a test because you're going to want to put a fair bit of that up each nostril. Last thing some people want to have on hand is tranexamic acid as well, and we'll talk about that towards the end. If everything else is failing, you might want to soak some gauze in this. It's also very handy to have on hand standby. So the dressing packs in most EDs come with these little gauze cotton balls that you can't pull apart, but try and find some actual cotton wool balls, and what you can actually do with these is unroll them. So cotton wool balls are just rolled up cotton, and you can make some little pledgets to soak in adrenaline or cophenolcaine or lidocaine and shove them up people's nostrils for a bit of anaesthetic vasoconstrictor before you start. Lastly, you're also going to want to have some packing devices, either rapid rhinos or Miracil nasal tampons to put in. Some silver nitrate sticks as well. You may want to have some long tongs and some packing gauze as a last resort, which is that's just a long ribbon gauze, and this is the BIP gauze, which is bismuth iodoform liquid paraffin is what VIP stands for, and that's what the ENT guys use. It's sort of a Vaseline impregnated gauze. We often don't do this in the ED. If you get to that point, sometimes you really just need the ENT guys down to help you out. So that's pretty much it. It's a good place to start, and we'll move on to the next section, which is how to actually manage the patient. Alright, we're back. We're going to have a look at Maddie's nose. So you can see I've got 2 hands free now. She's got 2 hands free. This is how you need the patient. You don't want them tied up to IVs and monitors. Take them off the monitor. They don't need monitoring. Let them relax. Tell them to sit forward. Lean forward a little bit. Just tilt your head forward. If the blood runs out on your nose, it doesn't matter. Like we said, one of the first things you might want to do is stick a couple of cotton wool balls soaked in adrenaline or vasoconstrictor local up each nostril. I won't do that to you exactly, Maddie, but they go up each nostril. And then you grab your 2 tongue depressors taped together, the butt plug, and pop that on. Just like that. Again, that frees up the patient's hands. They can give themselves a wipe. They're more relaxed. You then have time. I normally do this as soon as the patient comes. It's usually the first thing I do. I didn't do it to Maddie because you look ridiculous. So you leave that on. That allows you time to get your stuff set up and causes just some good consistent local pressure. Like I said, the vasoconstrictor, co-phenyl up there at the start. First thing I do with Epistaxis when you're ready to address the patient is you take the plug off, you take little pledgets out. Little side note about the pledgets, just be careful. There has been cases where people have sniffed, inhaled and aspirated pledgets up nostrils. So be a little bit careful that the patient doesn't inhale anything you stick up their nose. Most of the time there's a lot of clot there and you can't see. So when you get started, suction on, suction in one hand, light on your head, nasal speculum. I say just rest your head back for me and I'm going to have a look up your nose. So you gently with one hand, gently place that in the nares and gently open up and just have a look. Generally you'll often see the bleeding point. Sorry Maddie, that's a bit uncomfortable.
Right.
And then you pop your sucker up. Suction the blood, suction the blood. What you'll usually just see is I'll turn the suction off because it's a bit loud. A big fat clot sitting there, and you cannot do anything with the clot. There's no point spraying your co-phenyl up while the nostril's blocked with clot. It won't go in, so you need to get that clot out before you do anything, and that's where your plastic tongs come in handy. So while I'm looking up again, I've had a bit of a suction, and I'll generally have the nasal speculum, which is here. Suction on standby. Sorry, I'm making Maddie cry. Tickle your nose. So you look up like this, and you just grab that big sucker of a clot and pull it out, and it's disgusting. It's usually a big 5-10 centimetre clot, big slug that goes plop either into the bag or on the towel on the patient's chest, and they cough and gag. Oh, that's gross. But what that does is it empties out the nasal cavity. Then, that's when you get your co-phenyl tank. Sometimes you have to do this on both sides. We'll just do one on Maddie for now. And you go spray, 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 5 or 10 sprays up that nostril. I go and empty out the other nostril, spray, 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 spray. Give that some time to work. What also happens when you put the spray in is it'll wash the blood down the back of the patient's throat, wash a bit of clot down. They usually gag and go, blah, blah. And that's why you need the vomit bag there, because they'll cough the clot up again. So that's the first step. Clear the nose. Sometimes they do need to blow to get the clot out. That's fine, blow your nose. Then you go back. Sometimes you can actually, put the plug back on for a minute while you get everything ready. Then you've got some vasoconstriction, some local. It's usually a bit more comfortable. Have another look. See if you can see the anterior bleeding point on Little's area. If you can, that's sometimes a point which you usually often need a little bit of ongoing suction to do this. Again, this is why you need 2 hands. Pop that down. So sometimes you'll need to have the suction here, nasal speculum and a silver nitrate stick. And you'll see that sometimes you need to sit here looking like this and go, oh, hang on, it's bleeding a bit. Suction, suction, suction. There's the spot there. Great. Now I can silver nitrate it. If you want to roll the silver nitrate over, it's a good time to do it. And sometimes that works. If you don't want to silver nitrate, or it's pouring out too much and you think, look, silver nitrate's not going to work, or it's coming from further back, as long as the patient's well analgesed, that's the time you then can reach for your nasal pack. So there's different kinds, like we said, there's the rhinos, the Miracels, different ones. I'll put a little separate post about how to do a rhino because that's a whole separate talk on its own. These need to be soaked in water normally to soften them up. And again, with the balloon hanging down, you say, sorry about this, I'm a little bit uncomfortable, I pop the nostril up, and sometimes you still need the speculum to get it in, which you can dilate the nostril up if you need to, but that's a bit fidgety with 2 hands, so often just tilt your head back for me, nostril up, and you want to run it parallel to the floor of the nose. Roll your head to the side for me. So you want it, going a bit down or flat, not pointing up, you'll hit the turbinate. So look straight ahead again for me, Maddie, tilt your head back. So often we'll run this flat down along the edge of the nose until it's all the way in. One thing you can grab is a syringe. Then you grab a syringe with air, just gently inflate it until the patient's level of comfort or the bleeding stops, whichever happens first. If the patient starts screaming, don't keep going, deflate it a bit. They're not meant to be painful. Has been cases where people have fractured sinuses and cheekbones with these by overinflating them. So that's pretty much the first step of epistaxis. So if you get to the point of having a pack, and you've either silver nitrated it and it stopped, or you've gone onto a pack, the pack in and it stops, great, you leave it in, have a rest, move on. If you put the rhino in and it's continuing to bleed, it'll either start oozing out the front, dripping off the front of the rhino, or they'll just start hemorrhaging out the back, and you'll know that because as soon as the pack goes in, Maddie will start coughing up blood repetitively, and that's the time to think, well, hang on, we're at an impasse here, the first round hasn't worked. So we're going to have a break for a second, let Maddie have a rest, and we'll talk about the next step after that. Alright, we're back for the next part of epistaxis, which is what to do when your nasal packs don't work. Sometimes you pack both sides, they continue to bleed, and usually if it's a posterior bleed, the blood will just go down the back of their throat and they'll cough and gag and splutter and blah, cough up the clots, and that's a bit gross. If you've got a couple of options then, you can just take the pack out, respray with cofenalcaine, because remember it's a vasoconstrictor, have another spray, suck out any more clot that's stuck there, have a look and see if you can find a bleeding point to cauterize. And sometimes you will have just missed it on the first round and you need a second look. Sometimes if you've used one type of pack, like a Miracell, take that out and put a rhino in. If you've used a rhino, take that out and put a Miracell in. It's amazing, sometimes one will work and one won't. There's also different lengths of rhinos. There's 5, 7.5, there's a single balloon, double balloon. So there is a double balloon posterior bleed rhino you can use, so you might want to swap to that. If you've used a short single balloon one, try a double balloon one. So there's a few different options to try and control things. If you're really in a state and the patient's really hemorrhaging and none of these things have worked, that's when you can sort of move on to the more advanced sort of techniques. But these are invasive, do carry some risks, and not to be done if you're sort of haven't thought about how you're going to do it. So the first thing we'll talk about is sticking an IDC or a urinary catheter up someone's nose, inflating the balloon in the pharynx and pulling it back. That sounds good on paper. Practically it's a little bit tricky in an awake patient with a gag reflex. It's probably more of a technique for someone who's unconscious or obtunded who you want to stop facial bleeding. But the theory is that you, same as the other packs, anaesthetise, suction, clear the clot out, head back, and run the catheter parallel to the floor of the nose. And what you want to see is, open your mouth for me, Maddie. You want to, as the catheter goes down, you want to look in their mouth and see the balloon of the catheter, or see the tip of the catheter in the posterior pharynx. You can close your mouth, that's fine. If you can't see the tip of the balloon, or if there's a lot of blood and you can't see, you put your finger in and be sure you can feel the tip of the balloon in the posterior pharynx. If you can't feel it, you're not to inflate the balloon, you should take it out. There are cases, and I'll put some photos up, of intracranial indwelling catheter balloon inflation, which is not great. I was wondering for quite a while how you're meant to secure it. Let's just open these because it's a good demonstration. So what we'll get Maddie to do, we won't actually stick this up your nose. That's right, you just stick that up your nose for me, Maddie. Usually you use a 16, this is a 12, it doesn't really matter. Some 12, 14, 16 French catheter. So if we pretend that's up your nose, and tilt your head to the right for me, what you need to do to stop it going too far down, so you've inflated the balloon, sure it's the right place, is get an umbilical cord clamp and stick it around the end of the catheter like that, and it should just go clip. So that's good, so that'll stop it being inhaled. But if Maddie pulls that back against her nostril there, tilt your head to the side a bit more, if you put that up against your nostril, that's probably a bit uncomfortable, rubs a bit, yeah? Mm-hmm. So that's going to cause pressure areas and a bit of discomfort. So what you can do is get a bit of gauze out, just plain old gauze, fold it up into a little strip and actually just wrap it around the inside there, so the balloon, so the cord clamp isn't directly up against the nostril. Just provides a bit of padding in between the nostril. You can then put a bit more tension on, release the clamp a bit, tighten it up, that sort of thing. And you often need to put one of these in each side, put a bit of traction on the balloon, so you're pulling it forward. That's why, Maddie, you can let go. Mm-hmm. And so you're ending up with that sort of contraption inside your nasopharynx there with the balloon, tamponading the posterior element there. One thing that some people have tried, if they can see the anterior bleeding point, and just in, they think the bleeding's coming from just inside, and they haven't been able to stop it with a rhino. People are talking about tranexamic acid. So this is 1,000 milligrams in 10 mils. Cyclocapron, it's called, is the trade name. It's in a childproof packet. And we'll just see how this comes. So this is a liquid, so that's fine. Some places don't have the liquid tranexamic acid, and I have heard of people crushing up the tablets and making their own paste and shoving that up people's noses. I think that's a bit slapdash. So what you'd want to be having is, if you've got the liquid tranexamic acid in a vial, again, soaked cotton pledgets in tranexamic acid, shoved up the nose with some pressure on, or ribbon gauze. We can put our ribbon gauze in, which is just a big long gauze like that. Soak that in some tranexamic acid and gently pack the nose with that as well. The ENT guys talk about packing the noses with gauze, and you look at the textbook pictures, it looks all very beautiful, that the gauze is just beautifully layered like this inside the nasopharynx, and it looks very easy. It's actually really hard to do in an awake patient. It's very uncomfortable to pack the nose. So if you're going to move on to the next step, so the options for uncontrolled posterior hemorrhage are a double balloon rhino, an indwelling catheter, but as you can see, that's fidgety, probably a bit painful, and technically a bit challenging, or a ribbon gauze pack, which also, again, slightly tricky and uncomfortable because you need to use some long forceps like these, and you're trying to get that full length of the forceps down Maddie's nostril with the ribbon gauze on it. Clamped on like that, I'm going to be going shove all the way down the back of your nose, trying to pull the forceps out without pulling the ribbon gauze out, grabbing it and putting the next layer in. You can see it's kind of tricky, putting the next layer in. So if you're using these alligator tip forceps, they're a bit tricky. The other type you can use is just a long nose forceps. So they're a wider tip on them. You can see, imagine how that would feel, Maddie. How do you reckon that would feel if I shoved that up your nose right now? Took it to the side. So you're trying to get it that far in. So it's pretty uncomfortable, and I've seen the ENT guys do this. So that's what you want to use probably better, is not the alligator tips, but these long nose forceps. So you can see that they do just sort of want to hang on it. So it's a little bit fidgety. And also you can use the bib gauze. So I did want to make one point about positioning. We just made this whole great video with Maddie, and one thing I forgot to do right at the very start, which I see very commonly, is not the one positioning thing we forgot to do, is actually jack the bed up. What I was doing with Maddie, you can see I was hunching down like this and having to sort of look up and do this and do my back, and it's very awkward and uncomfortable. Always remember that beds go up. So don't be shy. Before you start, position, position, position. Epistaxis is all like real estate, it's all about position. So you can see now that Maddie's in a good position, much more comfortable for me to be doing this, looking up her nose. I'm not bending over, I'm not wrecking my back, I'm not sort of hunching down and trying to creep my neck and look up. I can access my equipment easier. It's a much better thing to do. Thanks, Maddie.
No worries.
I just wanted to do a couple of close-ups just to show you about technique and positioning as well, and how you use a nasal speculum and the suction. So this is a little nasal speculum thing here. It's got these two little prongs on it. The idea is that you hang it off your index finger like that, and use your thumb and your middle finger to open and close it. Some people sort of do it other ways. It doesn't really matter as long as you can hold it comfortably. Rest your head back on the bed there for me, Maddie, and just roll your head towards me a bit. So you need the patient's head tilted back a bit. You gently, come in close, Adrian, if you can, you gently insert it into the patient's nostrils like that. And this is why you need a good controlled grip over it, and just gently let it expand like that. We might even get you to come around this side, Adrian. Okay, so this is the view you want when you're looking up someone's nose. You want your nasal speculum gently placed just inside the nostrils, and just gently open them up. Not too hard, because you see Maddie's starting to wince. That's probably about as tight as you can let it go, and that way you can get your suction catheter in. You can see, if I put my light on, it's very bright, but this is the sort of view you want. You can come around underneath it, Adrian. We'll get the light right up there. You should be able to get a great view of the inside of the septum,
You can pop your suction in, suck the clot out, put your silver nitrate in, that sort of stuff. You can see if you're trying to do this with one hand holding a light and the other hand holding the speculum, you haven't got a spare hand to operate with. So that's the view you're aiming for. Sorry, Maddie. Gently open up the nostril, just like that. That's the view. You've got to get up someone's nose when you're managing epistaxis.
So you can see from that how much easier it is to do it with a head torch and magnification. What I don't like seeing is people doing this and then using the ophthalmoscope light, which is not as bright as the head torch light, putting a thing up and then putting the light up with the other hand, and now you've got no hands to treat the patient, do suction, get the clot out, do silver nitrate, that sort of thing. So you can see you can't do epistaxis holding a hand torch. Worst case scenario, if you don't have a headlight or magnification, you can get someone else to hold the light up the nose like that. Try and get the patient to hold it if you're on your own. But again, you'll see it's a little bit tricky because as soon as Maddie moves her head, she's out of the zone there. So I'm going to make you cry one more time, Maddie. So we do that, and that's not too bad if you can do that. But again, this will get in your way while you're trying to do things like your suction and that sort of stuff as well. It can get a bit cumbersome. So it's a last resort, but you absolutely can't do epistaxis on your own holding the light in one hand. You need two hands to do it. So look, that's epistaxis in a nutshell. I just wanted to go through the practical side of how you actually examine, position, prepare an epistaxis patient. There's good instructions. Most places will give you advice, and ENT guys will give you advice about how long to leave packs in, antibiotics, nose creams, nasal antibiotic ointment, all that extra stuff you do post-discharge. But that's pretty much epistaxis in a nutshell. Thanks, Maddie.
No worries.
So there you have it, a practical ED approach to epistaxis. If you have any other tips or tricks you'd like to share, please feel free to add them to the comments section below. If you like this video, please be sure to check out our new website, edprocedures.com, where we select the best FOAMED resources on procedures relevant to the ED and present them in a searchable website for quick and easy access for those wanting to learn new procedures and for those who need a quick refresher on the floor at work. If there's an ED procedure you need assistance with, feel free to drop us a line and we'll see if we can help.